Chairpersons, and I thank Jihad and the SIRS organizers for this opportunity. Going into the theme and increasing use of cystectomy, I mean, this is something that will happen. These are my disclosures. So I wanted to first bring about the preventive aspect because I think a lot of the managed treatment is preventing these from happening because they have morbidity, as we'll discuss. And of course, really, if you've done the cystectomy also robotically, even more reason why a robotic repair is probably the best definitive repair of this. If you try to look at the incidence of uretero-enteric strictures, it's a little difficult because it all depends on how closely you follow these patients. And if you look at more contemporary series where which have followed them beyond the traditional 90-day mark, you'll find that it ranges around the 10 to 12% mark. And Khurshid's group recently did a very detailed analysis of their incidence rates, and of course you'll find a slightly higher incidence the longer you follow them up. But these are the averages, and one should be careful when you look at very historical series which report a 2 to 4% rate, which I think underreports what the current stricture rate is. If you look at technical factors that can impact the incidence of strictures, several things have been looked at. One is the surgical approach, on conversion to robotics, especially with either the intra or extracorporeal diversion. There are ways to look at it. The type of anastomosis, you saw Dr. Wickland perform a Wallace anastomosis, and there are some data with that, and the technique of suturing. This was a study out of Vanderbilt that looked at extracorporeal diversion versus open and actually found no difference in their overall stricture rate. It was around 8.5% open surgically and about 12% robotically. Khurshid looked at his data, but these are, if I'm not mistaken, up to around 2012, where they actually found a higher incidence with intracorporeal diversion, although in the paper they mentioned several modifications are being done. At least there is a theoretical benefit of doing it intracorporeally in the sense that the anastomosis literally occurs inside. You have to mobilize very, very little ureter. In fact, the extent of ureteral mobilization is more reflective of the extent of node dissection rather than the anastomosis. You can really get away with very, very low thing. And you can also factor in how much ureter to get so that you avoid redundancy as well as you avoid tension. Looking at anastomotic technique, this was a meta-analysis that looked at Wallace versus Bricker and really did not find any difference with either approach. There is one paper that looked at continuous versus interrupted. Having said that, there are many centers of excellence that use either interrupted or continuous, and I think the overall results probably are not that different. The standard common sense things of avoiding excessive mobilization, etc., is important. I wouldn't be too concerned about the ureter very close to the bladder. Most of these ureters end up being excised. Having said that, you want to be as careful in minimizing ischemia. But the one thing that we are really excited about is the use of ICG, and at least our initial short-term results show a significant difference in our stricture rate. And just to give you a little example of what this shows, this is actually the iliac artery that gets perfused right away, and that's the bright green. And so you look at, then the bowel gets the ICG vascularity, and then you look at the ureters. One of the things you have to be careful though is that if the ureter is excessively dilated because of a lot of urine, you may want to decompress the ureter before you give ICG because there may be temporary ischemia. But here you can see that the contrast goes all the way to the clip, and so there is really no ischemic segment. Vascularity here is excellent. This is the second case. But again, in addition to the ureters, you also want to look at vascularity of the isolated limb, whether it's a conduit or a neobladder, as well as your anastomosis. So within one injection of ICG, you can really make sure, here in this case, the conduit is completely perfused nicely from end to end. There are no ischemic segments there. Quickly look at the anastomosis, that is nicely perfused. And then when you look at the ureters, now in this case, the left ureter actually has a transition point. Now, it may happen that this ureter has some vascularity that may improve, but if you actually anastomose in this green zone, and which you can easily do intracorporeally because you don't really need that extra length, the risk of ischemic etiology for your stricture should be avoided. So what I generally do is look at that area and then make a incision right there in green, and so you know that you've gotten a perfused ureter. So this is something that we now employ routinely. And this is a paper that we published in BJUI, again a retrospective review. There is a shorter follow-up on the ICG cohort. Having said that, till date we haven't at least identified a benign stricture. There have been a few malignant strictures, but not a benign stricture since giving this. And again, it's not a question of doing it just robotically. ICG is available laparoscopically as well as open surgically. So this is something that can be used in your practice. And I don't think that the stricture rate is going to stay zero, but certainly it is much lower than what we had historically, which is about 10.6%. Now, regarding the actual treatment of the strictures, this is a problem because it generally stays asymptomatic. By the time it's detected that ipsilateral kidney function may be significantly impacted, it can cause infections, needs interventions. One of my biases against endourologic management, I think a definitive repair done early has the best chance of long-term patency as well as preservation of renal function. Again, not many good quality data comparisons with these two, and many times the definitive repair cohort has had a variable period of endoscopic management, and so difficult to compare. But when it's a retrospective study, the patency rates between open as well as endoscopic repair were substantially different, and the preservation of GFR was also less. So at least from that standpoint, at least in my practice, I use endoscopic management. The nephrostomy tube is good to drain the kidney right away, but a stent is probably in preparation of primary repair, or sometimes the patient has adverse pathology, and if they've not had neoadjuvant chemotherapy, they may be requiring systemic therapy, and a stent that stabilizes kidney function is a good option to get the patient through chemotherapy, and then you can assess. But if the patient is doing well, and if you detect an ischemic stricture, at least my practice is to drain, protect kidney function, and go in and repair. The technical factors is I like to leave a nephrostomy tube in. It's always almost done to protect kidney function, but there is a very good role in intraoperative identification of where that dilated versus strictured segment is. It also keeps that ureter drained after you repair it, so chance of leaks are low. You must exclude urothelial lesions, so make sure you check the pathology of your discarded ureter in the cystectomy specimen. If there is CIS, you may want to scope these kidneys to make sure you identify that, so you at least can counsel the patients appropriately and use nephroureterectomy in the cases that have extensive CIS or upper tract urothelial disease. I typically use the same lithotomy position, and ICG is used liberally both percutaneously, endoluminally, as well as IV. So just to demonstrate, this was a left stricture right at the where it went into the conduit. This was a 70-year-old male. We go in, this is the sigmoid on the left. It is surprising to me, and I'm sure that the panelists will agree, that the amount of adhesions following a robotic cystectomy are very, very minimal. It's almost like the diversion was just done yesterday. The only site I see it is at the staple line. Other than that, everything seems free. And here we found the loop of the studor limb, and then the left ureter going across the aortic bifurcation there. And this is ICG in the nephrostomy tube. And you could clearly see the part of the ureter that is patent. I didn't want to dissect too much. This is the ureter that is tunneled underneath the sigmoid. And you could see the segment here, which matched the 1 centimeter segment that was seen to be obliterated on the antegrade dye study. And so once you open this, you can spatulate and just mobilize enough that you need to do an anastomosis. I generally will excise all this because this is urothelium. You want to send it out for pathology. And in this case, I ended up using that same opening that we had in the bowel. So that was sent out. Now you get IV ICG, which showed nice vascularity and perfusion there. And then basically I do interrupted suturing for these redo cases. Usually they have some degree of fibrosis, so I don't trust a continuous suture line. That is again ICG there. And then, doing a nice meticulous anastomosis, you can put the ureter to the bowel. Halfway through, like we do for a cystectomy, I will leave a double J stent in almost all these cases. A good way of introducing a double J stent is to put a 2 millimeter little cannula there. And so as you can see here, this can be done very, very nicely. And in the first couple of cases, I actually did start a little higher up to kind of identify the ureter more closer. But I think now with experience, the first thing I do is I keep an XI handy for these cases so that I can rotate and go up if need be. But I'm almost always have been able to find these easily close to the diversion. So while you sometimes may require to go higher up, it's usually not done routinely. So this is kind of the way in which you end up the anastomosis. I'm going to stop here. And this is actually the nephrostogram prior to removing the nephrostomy tube. You can see the stent nicely in position. And this is the most recent follow-up at 3 years showing no hydronephrosis and good patency of the ureter. This was actually an interesting case where this was a patient done prone. The left side, those bilateral strictures, the left stricture was extremely high. I had not even dissected that high. This part of the ureter was also not very healthy. So we ended up anastomosing, doing a repair all the way close to the kidney. And this is the right side was fairly low, and that's where the limb is. But this is actually, for reference, a cystogram done. And by error, pretty much I had left a very long Studer limb. And fortuitously, that actually helped me in this case, because I was actually able to take the Studer limb onto the left side underneath the sigmoid mesentery, attach this, and then do the right side, because that ureter was good in length. And just a follow-up X-ray, this was the most recent X-ray. You can see that that's the Studer limb actually on the left side of the aorta, the ureter going in on the left, and that's the ureter going on the right. And this patient, 2 years out now, has normal patent ureters. I think this is at least in my practice, my preferred approach of preserving kidney function and having long-term results. We just looked at our 8 patients that we've done robotically. Each one was done after a robotic cystectomy. The median time to diagnosis was about 7 months. I would be very careful in following these patients very, very closely. Most of these present early on, and so you do have an opportunity of preserving function. And at least over a median follow-up of about 16 months, we have not seen any recurrence. But again, we've not had a stricture in the last 18 months since using ICG, and hopefully it stays that way, and I never have to do this operation again or show this video.
Very nice.
So to conclude, just a last sentence, I think, be careful about this. I would just strongly caution against too prolonged of endourological management. Go in robotically, especially if you've done the primary operation robotically. These are pretty straightforward procedures. Thank you.